I appreciate the opportunity to talk to you guys. I was invited to talk about spinal cord tumors. It's kind of a bit of a hybrid title. Intradural tumors don't just include spinal cord tumors, but I am going to restrict the talk to spinal cord tumors. So just from a quick historical perspective, spinal cord tumors have actually been operated on for 100 years or more. Ellsberg was a very early neurosurgeon in the era of Cushing, and he actually did spine work and did spinal cord tumors in which they advocated a two-stage removal. That has long since gone by the wayside, but the idea was that you would do the myelotomy and then come back several weeks later, having let the tumor deliver itself. We don't do that anymore. The Pendimomas have been nicely worked on by Greenfield as long ago as the 1940s without mortality, which was great for those days. Microsurgery has made a very big difference, and of course, hang on. Microsurgery has made a big difference. It is only in the last 40 years that we have big series. Let's see, there we go. So the anatomy is obviously paramount. Knowing what's in the spinal cord is important if you're going to do surgery there. The key areas are going to be your posterior columns, because a lot of the approaches come down the dorsal median sulcus at the midline as a kind of a less intrusive way, using the sort of a natural plane to get into the cord. Or you can come through the dorsal root entry zone, which puts you somewhat close to the corticospinal tract. And so you have to kind of remember where the corticospinal tract is in order to avoid as much as possible motor injury. And there's a lot of other tracts in there, but those are the big two that we tend to think of. Let's see. Yeah. So the histology, the distribution thereof, is about evenly split as far as astrocytomas and ependymomas go. Those are the big two for spinal cord histologies. They together occupy about 88%, leaving the rest 10% for hemangioblastomas, which are their own special case. And then the other category includes things like gangliogliomas, subependymomas, et cetera. And we'll mention those briefly a little further on. Just to start thinking about astrocytomas, these, obviously the cell of origin is what it's named after. The borders in such tumors are definable, but they're not always well-defined, and often that's a clue that it is an astrocytoma. You see a fuzzy border, a little bit of an infiltrative quality to it. The picture you see there is not particularly infiltrative looking in the upper picture, but the lower one, it is a little bit fuzzy. It's got an enhancing quality. And so you can have a low-grade tumor such as the top panel suggests would be there. Also, though, there can be anaplastic astrocytomas, and very rarely you will see a glioblastoma in the cord. The glioblastomas are chaotic, tremendously nasty, and ultimately, I think, always deadly. We shouldn't say always, I guess, but I've never seen a patient with glioblastoma in the cord who actually survived in the long term. Happily, in the United States, in any given year, probably no more than 30 to 40 people get a glioblastoma of the cord. So at least the statistics are low. Ependymomas, again, the cell of origin is in the name. They tend to be centrally located. Astrocytomas can be, a bit sort of off to the side, eccentric, but an ependymoma tends to be central, and that's what this set of pictures, which is from the same patient, shows. In the sagittal view, you see the sort of sausage-shaped and well-defined area of enhancement, and then in the axial below, you see a centrally located tumor, also sharply defined. The cord in these tumors is compressed and displaced rather than being invaded. There are anaplastic ependymomas, but they are happily very uncommon as well. We don't see them often. And those are the ones that need more than just surgery. But usually a typical ependymoma of the cord is a curable tumor. And note, it is not biologically really similar, despite the name, not similar to the intracranial ependymomas, the ones that grow within the ventricles up in the head, those are stickier tumors and nastier and generally will need radiation, chemo, and so forth, but not ependymomas of the spinal cord, usually. Hemangioblastomas, their cell of origin is a little bit of a mired in controversy. Over the years, there has been a suggestion that there's a thing called an embryonic hemangioblast. I've never quite totally been able to understand what that cell is, but regardless, these do have a sharp margin. They tend to be sitting either at a peel surface or very close to a peel surface. That's an autopsy picture, as you see above, and see how it comes very close to the pia. Their noteworthy hallmark is they're very vascular tumors. And so that is what conditions how you take them out. And I'll get into those techniques in a moment. They are the only cord tumor typically these days where you might consider doing angiography. When I started training, we always did angiography on hemangioblastomas in the cord. And now I hardly ever do, unless you were thinking about embolizing them. But there, too, it's a little bit of a controversy as to should you embolize these tumors, given that they may share blood supply with the cord. And so you put risks of stroke and so forth. The textbooks give a lower percent, but in our experience, if you really look for VHL, von Hippel-Lindau disease, you'll find it in about 80% of those who have hemangioblastomas in the brain or spine. And you can see the histology there, how hypervascular they are. The special considerations, as I mentioned, do you do angiography? I mean, it might help you if you have a trouble figuring, or you think you're going to have trouble figuring what are the arterial feeders, because what you really want to do when you take these out is take the arterial feeders first. If you take a draining vein, a major one, and cut off its venous outflow, and you still got all the arteries putting blood into it, that tumor will swell in place and quite potentially, like if it has not been already detached from the cord, it's going to impact it in a majorly injurious way. And so try to take the arterial feeders first. The problem with that statement is that some of those arterial feeders may be deep and you won't get to them for a while until you've gone really around the tumor. We tend not to enter hemangioblastomas if we don't have to because they are so vascular. So en-bloc resection is the nice thing to do for them. For the others, the astrocytomas and the pendymomas, we tend actually to, sometimes we'll do them en bloc, but a lot of times we do them piecemeal. And don't feel that we're suffering because we get good results regardless. With hemangioblastomas, you need to make sure you, oh my God, sorry. Sorry about that. You need to check the whole spinal axis because you may have more than one in other places. The rare cord tumors, those in that other 2% category, the main ones, as I say, ganglioglioma and subependymoma. The picture you see there is a ganglioglioma, which is a kind of a chaotic looking tumor. And in fact, if you look here at others, this guy has a scoliosis that prevents you from seeing everything in this single sagittal plane. And then you look at the T2 and he's got areas of cystic change, potentially syrinx. And so we looked at this and we're thinking, okay, this has been read as an anaplastic astrocytoma by the radiologists, but the presence of the scoliosis, and if you look at the vertebral bodies, they're very thin and sort of not, fully formed in many of the levels. That implies that this is a long-standing tumor and one that actually should be a fairly benign histology, and gangliogliomas are that. So he got a very actually good resection and is doing well. The other main category we see are the metastases. Now, that may be a little bit because I work in a cancer center, and the breast cancer and lung cancer, they do metastasize to the spine. We don't usually end up operating on them except in special circumstances. And there's a whole bunch of other things, but those are the ones to really think about. So that's ganglioglioma. The presentation for the spinal cord tumors, myelopathy, of course, posterior column dysfunction or central cord syndromes can be part of it. It all depends on, the position of the tumor within the cord and how it's, how big it is, how disruptive or distortional it is to the adjacent tracts. You can also get a lower motor neuron motor deficit at the level of the lesion. And if, as with the ganglioglioma patient I just showed, you have onset in childhood, you can get a scoliosis, and usually you get bilateral symptoms. So MRI is the best thing to do for these tumors if you're going to work them up. You don't have to automatically get CSF studies if you see something that looks like, these particular diagnoses. But if you look at it and you think it looks funny and it just doesn't quite fit, then CSF studies are useful because there are people who have MS plaques in the cord that mimic tumors, sarcoidosis in the cord, ditto. So those things you need to do CSF studies to distinguish, because you're probably not going to want to operate and resect a MS plaque. Maybe you might want to biopsy a sarcoidosis if it was not evident somewhere else to biopsy. But, so usually you can do the MRI, not the CSF, but once in a while, just keep in mind that you might need it. Now, they do tend to have, in any of the main categories, whether they be hemangioblastomas, astrocytomas, or ependymomas, the syrinx. So this patient had an ependymoma, which actually is not on the picture. This was the original scan that was done outside of our hospital, where the surgeon looked at this, went in and did a laminectomy up in the neck and took some sampling of the cord, sent it to the pathologist, and had it read out as a low-grade astrocytoma. What he was biopsying was the edge of the syrinx, and he had not completed a full survey of the spinal axis, thus did not see the enhancing nodule that is at T11, which is the real source of all of the syrinx. The syrinx is secondary to that. So this syrinx goes really all the way up to C1, and the myelopathy is from the syrinx, much more so than the tumor, which is very limited in its location. So the lesson there is you really need to do a whole scan, follow the syrinx all the way to its end and see if you've got a tumor on it. You'll probably find one if it's a tumor case. And then you operate on the tumor, but don't biopsy the syrinx. You'll get a misleading sort of diagnosis and delay the ultimate helping of the patient. Syrinx is reversible. When this guy had his tumor removed, as you see way down at the bottom, there's a laminectomy now. The syrinx faded. It takes between 2 and 8 weeks. The mechanism of the formation of the syrinx isn't really well known, and thus neither is the mechanism of its disappearance. If the syrinx does not go away in that time frame, then you might suspect that there's still some tumor present that you may need still to go after. The basic surgical methodologies here are, you have the posterior approach that is generally used, a laminectomy over the involved levels. Once in a while, you might need to do a pedicular removal to kind of open up from the side if there's a tumor that's anteriorly placed, say a hemangioblastoma that comes to the surface of the anterolateral quadrant, not the postero, but happily those are not the usual. So you don't always get to just do a laminectomy, but usually. The laminectomy needs to be wide enough to really expose the cord side to side, hopefully not wide enough to impair the lateral portions of the vertebra, the facets and so forth, because you don't want to impair mechanical stability. Ultrasound is a very useful tool to see what's beneath the dura and to check and make sure you're in the right spot. And that you're high enough and low enough in your laminectomy. The microscope is a definite must-use for these, and we do real-time monitoring of cord function using both motor and somatosensory evoked potentials. Now, when you go in there, you have to think, which way are you going to enter the cord? As I mentioned earlier, the two basic methods are going to be down the dorsal median sulcus between the two posterior columns versus the dorsal root entry zone approach. And both of those, can be used with reasonable safety as long as they're done with delicacy and care. The DRES is a little more fraught because it's a little closer to the corticospinal tract. And so you may be bumping into that a little more if you choose that. But sometimes the tumor is just much more amenable and it's location to address versus a dorsal midline. We generally tend to put peel retraction sutures in the sense that we don't want to be bumping against the posterior columns or against, whatever part of the cord we've gone through on multiple repetitive occasions. That's what can cause, neurological changes post-op. But the peel retraction sutures, if placed with gentleness, are going to do a good job in preventing that. A frozen section is typically done because, these tumors, they mimic each other sometimes, and you don't really know what you're getting into unless you get a frozen section. So we get one early. We like to develop a plane around the edge of the tumor if possible. But as I said also, we don't necessarily automatically assume that we have to do an en bloc resection, because these tumors tend not to be, possible really to do in a truly oncological way. You can't take margins of the normal cord. You have to really go right along the plane of interface between cord and tumor. So I find that sharp dissection is a very useful method, and one that's actually more gentle than blunt. And we do internal debulking in particular if there's no plane evident. But sometimes even if there is, and it's just a big tumor that we don't want to have to, do a lot of cord manipulation to extract out laterally. The coronal venous plexus tends to be somewhat expendable in the sense that it is a network that has a lot of interconnections. And so if you take a vein here and there, you're not typically going to hurt things. Now, this is a video. It shows kind of just the way of getting in. We're going at the midline, and we've identified it partly by ultrasound and partly by looking for where these little vessels are taking a dive down into the median sulcus. You can see that along the edges of that, there are vessels here, for example, that confirms that we're in the right place. There's the tumor. We're using a Roton number 3 there to get around the edges. That's a place where we need to cut, where it's a bit adherent. But here the Roton is doing a lot of the work in getting this out. Ependymomas tend to have their feeding from anteriorly, branches of the anterior spinal. So that's where you tend to get your bleeding from. And that's what it looks like when it comes out. Here's a second one in an NF2 patient, again, going down that midline level. And this one's smaller, but it's going to be done with sharp dissection. As you can see, it'll come out quite nicely there. Yeah, there's a kind of a knob that's going off to the side a bit, and that requires us to kind of push out there more. So, So a couple of cases here. Clinical history of Pendimoma, a 40-year-old woman who had slowly progressive weakness of both legs as well as paresthesias and some pain and sphincter disturbance to a small degree. The patient was hyperreflexic, so she's myelopathic and has this sausage-like well-defined enhancing lesion within the cord. On the sagittal, it looks like it occupies all of the cord, but it doesn't really. It's actually just stretched it out and thinned it circumferentially. And there's a syrinx above that we can use to get in there. We like syrinx. It helps a lot. So we uncover with our laminectomies the full extent of the tumor. We use the syrinx to start the gaining of access, because sometimes it'll get us quite down along to the front of the tumor very quickly if we pass through the syrinx, and we don't have to do a lot of retraction and pushing to get there. Will this patient get spinal instability? It's always a question with a spinal cord tumor patient. It's why we preserve the bony elements as much as we can, but you don't know. And if they do, it tends to be a swan neck deformity, presumably because not only have they lost some of the bone strength of, that keeps their spine stable from the laminectomy, but also because they may have impairment of the motor function coming out of this part of the cord where the tumor was, and that goes to some of those paraspinal muscles that keep things strong as well, or at least contribute. This is an ependymoma that shows with the peel retraction sutures pulling it out, and there it is sitting there very clearly different. It's pulling out nicely. It's gone. It usually takes about 3 hours or so to do what we just did in 3 seconds. So for a hemangioblastoma, here's a classic case, a patient who's 28 years old with a pancreatic cyst. You see down here, pancreatic cyst plus lesion in cord usually means they have VHL. You look for renal cysts and other things as well in the spectrum of VHL. She has numbness first in the left hand and arm, and then proceeding into the left leg. Has an exam that's also got some hyperreflexia and some, decreased pinprick sensation. So, and we see here the darkened area, the syrinx is in the cord, going right up to the cervical medullary junction, and down below as well. And as we see here, that's that same syrinx on a little bit grainier view with the tumor quite brightly enhancing, and a lot of edema in the cord. And so there's the tumor. You could look at that and say, well, could that be an Pendimoma? Yes, but the patient's got some VHL stigmata beyond that, so it would be very kind of unusual to have an Pendimoma in a patient with VHL. The hemangioblastoma is the usual one, and that's what this turns out to be. This is what it looked like. You can see this is a very classic hemangioblastoma look with all these spider web of large draining veins. Some arteries are feeding into it, but what we're more seeing is the veins. So when we go in to detach this, we go around the edge and we sharply cut the pia, and as we go, cut any little arterial feeders that are going in. We come to the veins. We like to keep those veins because we know if we take them prematurely, as I said, this will swell and it will not be pretty for the patient post-op. This dark stripe here is an area of thinning over the syrinx that's extending up above where the tumor sits. And so that's part of what we'll do is we'll open this. We won't be having to go through any functional spinal cord to open it, and it'll get us a nice corridor that takes us down to the front of the tumor. On ultrasound, a hemangioblastoma often has flow voids like this one with a very big flow void in it. If we were to do a color Doppler, that thing would have blood rushing through it. And so they do show well on ultrasound, as do the Pendimomas. The astrocytomas can be a little less, firmly established in their boundaries, but you still can see them well. There's the pitfalls of, doing these operations. If you do your laminectomy too widely, you get into swan neck type of issues. You can mistake the syrinx for the tumor, as we showed an example of. That's not good. Insufficient dissection into the cord, meaning you try to go in and find this, but you just don't go deep enough and you come out empty-handed. The ultrasound will help you avoid that problem. And then, of course, if you don't take all the tumor out, which is the goal to do, but sometimes you just can't. It's just not safe. So it's not necessarily a bad thing. We take care in positioning the patients. We always do the MEPs and SSEPs. We like to cut the dentate ligaments in order to allow the cord some freedom of movement so that when you do your gentle retractions, their effect is less felt. Gentle. The word gentle should come up many times in this talk. That's what you have to do to be successful with spinal cords. I like piecemeal removal. We actually published a paper saying that the best way to take out, this is years ago, the best way to take out an Pendimoma from the cord was to do it en bloc. But I actually, as I've gotten experienced over the years, I tend to do them piecemeal because I think it makes less retraction. And finally, although we put at the end, gel foam or flow seal or Surgiflow into the cavity, we tend to try not to leave anything behind in the cavity. Once the bleeding has been controlled, we like it to be nice and empty. Again, just to kind of have less potential sources for trauma to the cord. The complications are predictably what you see here. I won't go through all of them. You have to be careful at the upper cervical levels that you may get some respiratory insufficiency due to impairment of the phrenic nerve output. But I will tell you, I have never seen that in 30 years as an attending in neurosurgery doing these kind of cases. But it does happen. It's in the book, so I must mention it. Immediate decline neurologically after surgery is common. It's not inevitable, but it is often seen some decline, especially in older patients, those who've had radiation before, or those who are having a reoperation. And so those are more susceptible to loss. But you can have some pretty profound deficits that scare you a lot as that you watch the patient, waking up with a with a paraplegia or even a quadriplegia, and then find over the next few days that they actually start to recover. As long as you've had extreme care in how you took that tumor out, you're usually going to be okay. The neurological status has been shown 3 months after surgery. Half of them, it's better. So if they're, people who have a deficit, it'll have gotten better in half, stable in about 35 or 6%. And then the rest, like about 10% here, are actually worse. Now, some of those worses will get better over the time after 3 months. I've seen people get better typically for, in the first 6 to 9 months. We see improvements. We have to be patient. They have to do physical therapy and stuff. But I had one person who actually snapped back to normalcy 2 years after his operation. So weird things happen with spinal cords. The principles of recovery, we like to keep them in bed for a day or two to minimize a CSF leak. We do use Duraseal on the CSF, on the suture line, on the dura. A slow steroid taper, we just have to be patient with them, and a formal rehab program is often helpful. The better the condition of the patient neurologically before surgery, the better they will be after. Thus, I take that as a kind of a reason that we don't really like to wait for them to show significant clinical decline. We will sometimes, if they're intact, wait for the tumor to show some signs of growth, or if they're extending their syrinx or that kind of thing. Radiological changes may trigger intervention. And if they maybe just start to get a little tiny bit of change, but if you let them get big time worse, that's not a good thing. They won't do as well. So this is my last slide, I think. The rules of McCutcheon on spinal cords are, first of all, you won't know what you can do with a spinal cord tumor unless you open up the patient, go in and look. Many times you will get a patient who has an awful looking tumor and you think, oh my God, this is not something I'm going to make a dent in or I can't safely do. But yet when you go in and you do your, standard maneuvers and go down the central, the dorsal median sulcus, get in there and start looking at it, you actually can find out that you can do a whole lot. You may not be curative, but you can certainly decompress it a lot and hopefully make that patient safer in doing so. The midline, number two, is the midline is often distorted because the tumor, if it sits right in the middle, it'll have the midline in the middle. But if it's a little eccentric to one side, then the midline shifts. So you use the ultrasound to sort of help you see where the midline is, and you look for those diving vessels that are very nice clues. The syrinx is always your friend. Number four is that incomplete, safe removal of a benign tumor is better than doing complete removal of that tumor with a neurological decline. A benign tumor is often not going to give trouble for a long time after surgery, even if you have to leave a little bit behind. So keep in mind the histology of these things. It matters. Gentle. Sharp dissection is safer than blunt, and it's very important to know the nuances of the different tumor types, as I've tried to kind of give you a little bit of insight into through the course of this talk. So I think that's what I got. Yes, thank you very much for listening.
Thank you, Ian. That was incredible. Great to see you and hear you again and hear all the wisdom that you have after so many years of doing this type of cases.
Yeah.
A few questions. One is, how do you handle intraoperative call from the side of the room where they tell you as you're doing your work that they lost SSCPs and motor evoked potentials? Do you keep going? Do you back off? How do you handle that? That's question one. Question two, when do you find yourself, how do you manage intramedullary Mets, spinal cord?
Yep. So the answer to question one is I retain a profound degree of skepticism as to whether those potentials that have changed are actually going to correlate with a neurological change in the patient, post-op, because there have been many times where, they lose half their potential and we can't think of anything that we've done at that moment I mean, sometimes they'll lose it even just when you're opening the dura and you basically haven't touched the cord, So the first thing that I do is I cut the peel retraction sutures, just in case, because that is a potential thing that we can fix. The second thing is I ask the anesthesiologist if they've done something strange with the anesthetic technique, because they may, they switch anesthesiologists. They don't always talk to each other and sign out properly when they make their switches. And I mean, you can be surprised. They may have done something to actually cause it. We ask about the blood pressure, because if it's low, there's all these physiological factors, that can do it, that are beyond anything that the surgeon is actually doing that's traumatic. And then finally, we put in some warm saline, or isothermic saline, just so that the cord isn't cold. And if we do those things and, it's still like we can't figure out what it is, I will actually, if I'm well advanced in the operation, I'm just going to press on and finish the removal of the tumor. And I will say that doing that, not that we've made it a formal study, but doing that does seem to be completely okay in terms of, the patient is going to actually come out of it with, decent function. Now, if a patient, say you've been retracting, laterally, and the corticospinal tract might be a little bit affected by this, and you've been doing it, and it's been a while, you may need to quit. I mean, there you have to just judge it. It's a judgment call, really. There's not a science to it. So that's a long answer to that, but it's a kind of a complicated question. And we routinely get drops in the potentials, whether it be motor or somatosensory, and ignore them and move on. The main reason that I actually do those is because of the extreme cases sometimes that will come up once in a while, and also because medical legally, if you don't do it, you're at risk from, if anything did happen and you didn't do it, then you are at risk to be sued. So part two, the question about the intramedullary Mets. Yes, that's a very good one. So we published a paper on them. And essentially the paper is a cherry picking of, the ones that we operated as opposed to all those ones that we didn't, right? And we don't operate on them if they're reasonably small, if they have minimal sort of deficits associated, or if they have a certain degree of radiosensitivity. Usually they will be treated with radiation. And we also have to consider the overall systemic metastatic profile of the patient, because, if their life expectancy is 8 weeks from having 150 Mets in their liver, then that's not going to be a person that you're going to want to operate on. But the ones that we do operate on are the ones that are in pretty good shape from the cancer standpoint. Their life expectancy is considered to be like an extensive one, a long one. And they have a tumor that is starting to cause a myelopathy, and it's distressing everybody. And so we'll do it, but it takes a lot of discussion to decide. So in that paper, I don't remember how many, but it was something like 10 patients or something. And so that includes usually breast cancer you won't do because that's sensitive to radiation. But we've done, we did a case of cervical cancer. We've done lung cancer. A good one actually to operate is a renal cell carcinoma, because even though you think it's going to be a bloody mess because it's renal cell, actually, usually not so much. And they have a very nice defined plane. They sort of act like little hemangioblastomas. So you can, which is a disease that you get with VHL also, right? So you can usually get a renal cell out in a nice way, and they can do well, because also renal cell often is a disease that they'll live for a number of years. So that's sort of like the ideal type, is a renal cell carcinoma. A thyroid.
How about the melanomas?
Yeah. So melanomas are dirty. They're soft, they're sticky. We have done one or two, but it's not my usual first choice. Somebody twists my arm into doing it. Melanoma, and often, if you have a melanoma in the cord, you've also got a bunch of melanomas in the brain, which is another reason that you would think, not to do. When we have operated on melanoma, typically those patients will show up with leptomeningeal disease a little bit down the road. And you don't know if that's because we, opened the cord and caused it to spread into the CSF space, or if it was going to happen anyway, just because the nature of the disease that put it into the cord is also putting it into the subarachnoid space. So it's not an easy algorithm to follow, but you sort of pick your patient with the longest life expectancy, patient with a tumor that maybe isn't going to be radio responsive, but is going to be predictably not too bad to take out cleanly. So renal cells are good for that. Melanomas, not so much.
Great. Thank you.
Sure. Yeah.